everyone. This presentation is again just a brief overview of healthcare issues for women and other stigmatized populations, which includes individuals of sexual minority and a real brief touch on those with mental illness. What we do know from our previous presentations is when we look at the healthcare disparities and the inequities and those social determinants, those continue to show up throughout the vulnerable populations that we work with. For women, the aspect of reproductive health comes in and is a little bit different than when we're looking at general population. And then we have some other issues related to those of a sexual minority, but then also too when we're looking at those with mental illness, it's really going to go back into those social determinants that we deal with on a daily basis with our clients and how those prevent good physical health. So let's get started. First of all, for women, just taking a look at women's health, women typically live longer than men, okay? So that we know that women are going to live on average to be 81 years old, which is an improvement. But for women in the United States, this is a life expectancy much less than those women who are in Asian or European countries. The leading causes of death for women in the United States are heart disease, cancer, and stroke. And we often don't think about that. We always think about breast cancer as being a big driver for women's mortality, but it's really not. Cardiovascular disease is obviously the main area that impacts women's physical health, and cancer is going to come into lung cancer. So we know that 45.2% of women over the age of 20 have hypertension. That's almost half the women over the age of 20 have some aspect of hypertension. Just a little under half the women over the age of 20 can be considered obese, and a small percentage of women over the age of 18 smoke cigarettes. So there's a small percentage that do, and a small percentage of women over the age of 18 will report fair or poor health, and 11% of females under age 65 have no health insurance. So this is a snapshot of the physical situation for women in the United States currently. Again, heart disease is a common condition for women. And when we have heart attacks, we typically don't present the same as a male with the typical signs of the pain in the arm and pressure on the chest. We come into the emergency room and we have some lightheadedness, some fatigue, abdominal pain, and many, many, many times the heart attack goes undiagnosed in women. And until something happens down the road, or if it's severe enough, it may be undiagnosed for a long time. Cancer kills about 250,000 women in the United States annually. We know diabetes is the 7th leading cause of death in the United States, and it leads to the complications of heart disease, strokes, amputation, blindness, kidney disease, which is all of those other chronic conditions that we've talked about already in this module. Osteoporosis is a condition that disproportionately affects women. Men are not exempt from it, but it disproportionately affects women, and it affects 8 million women over the age of 50 and can cause 2 million fractures at a cost of $19 billion annually. So osteoporosis is a very significant health problem for women in the United States. And then Alzheimer's disease disproportionately affects women. 2/3 of adults age 65 and older with the disease are women. Part of this is going to be women do live longer, and we already know that age is a risk factor for Alzheimer's disease. 60% of the nearly 15 million Americans who provide unpaid caregiving to someone with Alzheimer's disease is also women. So Alzheimer's disease is going to be a huge, huge health factor for women, whether it be the disease impacting them directly or whether it be them providing care for somebody who the disease has impacted. Why is women's health so important? Well, women actually throughout the world and in the United States still represent the cornerstone of the family's overall health. It's typically the women in the family who ensure that the children and their loved ones get physical care, get access to health care. They're typically the drivers behind this, and oftentimes they will forego their own physical health to be sure their loved ones have what they need and get access to what they need for their physical health. So, we're key in maintaining healthy families, accessing the healthcare system, um, and we will access it more often than men on behalf of ourselves as well as on the behalf of our children. Many women obviously become pregnant and give birth, and which is a significant health event, and then they typically become the child's primary caregiver. And again, that role greatly influences the health of the overall family. Elder long-term care issues. Again, we've already touched on Alzheimer's and the impact that has on women. Because women do have a longer life expectancy, we have higher rates of disability and chronic health problems as we age. We typically have lower incomes than men on average, which then puts us at greater risk and being able to access health care and an increased reliance on state and community resources, again, as we age, because there's those structural barriers, again, within the Social Security system. If we go back to who qualifies for disability, who qualifies for Social Security, women are at a disadvantage, especially for women who have invested their lives in managing a house and raising the children, which is like the most important career in our society. Yet those women are 100% dependent upon their husbands' benefits at the federal and state level to be protected down the road in terms of their physical health. So they're sacrificing their autonomy, their independence to raise and provide for this most important institution in our society, again, which is the family, and then they're disproportionately relying on their spouses or their partners' access to Social Security disability, to Social Security benefits down the road. So it sets women up long term at a big disadvantage. Women also typically leave employment, even if they're a professional or a primary essential employee. They leave employment to provide child care, to provide elder care. And again, this reduces their ability to earn and their ability to access good insurance or benefits for their physical health. So there's kind of a double whammy in there for women, and why it's so important for us to focus on women's health. And one key factor that many people don't realize is women are very much underrepresented in research. Research for healthcare, whether it be cardiac care, whether it be cancer, whatever it is, women typically have been underrepresented. So any research findings are based on men and not on women, but we do know our bodies operate very differently. Part of this goes back to earlier laws which prevented women who were in childbearing years from participating in research and clinical studies because of the risk that it would have. That has actually been lifted some. There are additional requirements that women, or pregnant women specifically, have to go through to participate in health studies. But keep in mind that most of what we know about chronic health conditions is based on research in which men, and primarily Caucasian men, were the participants. And we know from a research perspective, it's very hard to generalize those findings to another population, especially when it's women. So women have been very much underrepresented historically in research in healthcare, and we just don't know as much about the specifics things related to women and the hormonal aspects and the body fat, because women have more body fat cells because biologically they need those for reproductive purposes. So we just don't have a clear understanding. Things are improving, but again, much of the knowledge that we have related to those chronic conditions that we've looked at in this module are based on Caucasian male research and not specific for women and not specific for ethnic racial minorities of all sexes. And again, unique to women is the aspect of reproductive health. So when we want to define reproductive health, we're going to use the World Health Organization's definition. And first of all, the World Health Organization's definition of health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And then when we talk about reproductive health, they apply this same definition to all matters relating to the reproductive system and its functions and processes. So reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. So this is the individual autonomy of the person, male or female, but we're going to focus on female in this area for reproductive health, in terms of being able to make decisions about their body and have adequate access to resources to make a determination about their reproductive health. The Affordable Care Act, one of the areas that passed that, again, so much has been political about this, but like we looked at earlier in this module, one of the benefits of the Affordable Care Act was that there's insurance transportability, so the pre-existing condition was eliminated. Children could stay on their parents' insurance longer. But what it did was, when it provided for the private marketplace insurance, and it made all insurances offer the same basic components. So no matter which insurance you purchase, the same basic components had to be there. Now, they could put extra bells and whistles into it if they wanted to, but everybody had to be on an equal playing field. And one of these equal playing fields was that insurances had to provide access to reproductive health without deductibles, and that meant birth control. And of course, this sent everybody up in arms because we have, in our country, we have such moral and religious divides related to birth control and what that means. So the Affordable Care Act did put that into place, but again, there's been subsequent lawsuits. And in 2020, the Supreme Court did rule 7-2 that employers with a religious or moral objection to providing contraceptive coverage to their employees may opt out without penalty. Okay? Now, Hobby Lobby was one of the big companies behind this lawsuit in winning this. Hobby Lobby claims moral and religious objection because they're apparently a family-owned business and they object to it. So individuals working at Hobby Lobby now do not have access through their insurance for contraceptive coverage. And there's others too who have taken on this definition of religious and moral obligation. Now, whatever we want to say from our religious and our moral standpoints, we're talking about social justice and equity here also. So remember, there's oftentimes when individuals don't have but a couple of choices, and maybe there's women that are employed at Hobby Lobby or at the other corporations that have taken this stance. They have a good paying job. The insurance is good, other than now they've lost their benefits for contraception. So they don't have a good choice of leaving that job because it does provide what they need for their families, but yet now they're restricted. So their ability to make a decision about their reproductive health has been impeded by a lack of financial support to, if they chose to use contraception, they now have to provide that out of their pocket. On the flip side, we can look at Viagra was the big deal that came out years ago. And what I'll tell you is actually, when my daughter had her heart transplant, she was treated with Viagra. Viagra was originally a drug that treated pulmonary hypertension, and for people who had altitude sickness or pulmonary fibrosis or the pulmonary hypertension, and it's very effective for that. But they found it had a secondary benefit when they were doing their trials, and so it was approved for the secondary benefit and not approved for the pulmonary hypertension. But the secondary benefit is which it treated male impotence, and because male impotence is a medical condition, then insurance will cover Viagra and other similar drugs because it's treating a illness, even though that goes back to being related to a sex life, choices, and reproductive health. Whereas contraception is viewed as not treating an illness, but as a preventive measure, and so therefore there are restrictions on it. Again, it's highly controversial, but coming from a social work perspective, a social justice perspective, a client autonomy, and the client's decision or the client's ability to make decisions about their own body, this violates a client's decision to do that. And it should be the individual's decision within the context of their religious beliefs, within the context of their relationship to a higher power, when they make a decision about reproductive health. And it should not, from a social work professional standpoint, be a government impeding that or be a government officials making that decision for somebody else. So this is where this controversy happens. And of course, you can't talk about reproductive health if you don't address the issues of abortion. And again, abortion has a lot of legal, moral, ethical, religious aspects to it. And it always will. It's just a part of the human condition that's always going to have those deep divided differences. But what we have to know from a social work perspective, again, in working with our clients, is we have to understand the laws. We have to understand what's impeding decisions. We have to understand in how to best advocate for our clients. And what I can tell you is Texas, the Governor Greg Abbott just signed this into law, I believe in May, and Texas now has like the most restrictive abortion law in the United States. And it bans any procedure as early as 6 weeks in a pregnancy. And oftentimes women don't even know they're pregnant in that first 6 weeks. You may not have skipped a period. You certainly may not have taken a test. You may not have a clue. It also absconds the government from enforcing this and places it on private citizens. And they were very strategic in doing that because now there's no way to sue the government over this because the government's not enforcing this. It's really kind of a sneaky law here. What it does is it bans abortions after a fetal heartbeat has been detected. Again, professionally, we're setting aside our moral and religious beliefs at this point in time, and we're looking at this from a social justice perspective. And it includes... Okay, the ban includes all cases where a woman's been impregnated as a result of rape or incest. I'm going to step out and say no woman gets up in the morning and says, oh, gee, I'm going to go have an abortion today. I'm real happy about that. It's not that way at all. However, in certain cases, it could be that it may be the best outcome for all involved. But the bottom line is no matter what we believe, what we think, as licensed social workers, our clients should have a choice. They should be able to make a choice about their own body and be able to not be impeded in that choice by a regulatory entity. So that's the bottom line here. There is an exception in this law for medical emergencies, but they're very rare. But again, right now, Texas has the sneakiest and the most restrictive abortion law in the United States. And it's sneaky simply because the way it was set up is it prevents individuals or organizations from suing the government over this, and it puts the impetus back on private citizens for this. So it kind of shifts the power here, which is going to be interesting to see how this plays out in the future, and also very concerning as to how this could play out in the future when we're talking about the vulnerable populations that we work with and the precedent that this example could set. And again, Texas is not going to be the only state that's going to pursue this, because we now have a more conservative Supreme Court that will embolden the lawmakers to pass those more restrictive laws in these areas. And again, aside from moral religious objections, there are medical risks that are associated with legal abortions, and then there's a much higher risk for abortions that are done outside of those legal settings. And again, there's a lot of physical risk to the woman whenever they have to seek an abortion for whatever reason. And pelvic infection, there can be an incomplete abortion that actually requires a surgery, blood clots in the uterus, heavy bleeding. That should be heavy bleeding, not health bleeding. Heavy bleeding, cut or torn cervix, perforation of the uterus wall, anesthesia-related complications, and then infertility and future pregnancy risk also happen. So it's not a one in, one out type situation. There's all kinds of physical risks related to that. And if we take a step back and we look at education, and we look at access to reproductive health, and we look at providing opportunities for women to learn about these options, if we reduce domestic violence, and if we can address the crimes against women in terms of rapes and incest and things like that, then fewer and fewer women will feel like they need to make a choice about terminating a pregnancy. But we have a lot of work to do here. There's a whole lot of work to do here. And unfortunately, from a social justice standpoint, in the last several years, we've taken many steps back, and women have actually lost some of their rights to choices just over the last 4, 5, 10 years or so. We're actually taking a step back in terms of women's choices and their ability to make reproductive health decisions that impacts their overall physical health. And then when we look at actual childbearing, carrying a pregnancy and actually having a child, it's not without risk. Fortunately, in our country, there are less risks than there are across the world for women, and it depends on the age. Obviously, very young girls, teen pregnancy, young girls, victims of incest, have a greater risk of carrying a child to term and giving birth because of medical complications. But basically, the risk of dying as a direct result of pregnancy and childbirth is less than 10 in 100,000. Now, for African Americans, it's a higher risk, and it's 22 in 100,000. Again, those social determinants are impacting these outcomes here, which also include lack of access to good health care, lack of health insurance, lack of transportation. All of that we've talked about will also impact women in terms of childbearing and health outcomes. So we do know that approximately 15 to 20 or every 100 pregnant women require a cesarean delivery. 1 in 10 women may develop an infection during or after delivery. About 1 in 20 pregnant women has high blood pressure problems, and it can develop during the pregnancy. 1 in 20 women suffer from excessive blood loss at delivery. And then we know postpartum depression really can impact women after giving birth. And it's from a mental health standpoint, obviously, but it's also from a physical health standpoint, because the two are interacting here. So in terms of reproductive health, we actually have to go back and we have to look at our NASW and professional codes that guide our professional steps that we take to help our clients. The first ethical responsibility that we have then that's outlined in our NASW Code of Ethics is our commitment to clients. Our clients' interests are primary, so we actually have to set aside our own beliefs, our own We are not asked to give up our beliefs, to give up our opinions, to give up those things that are core to us. But if we've chosen to become a professional social worker, then we are acting in terms of advocating for a client, and their interests are primary over our interest. This can become difficult for many of us, but it is something that we have to work on, and it has to do with that self-awareness. Social workers must respect and promote the right of clients to self-determination, which clearly include the client's right to make choices about their own reproductive health. Again, this is embedded in our code of ethics. So we need to advocate for clients to have access to the resources that they need so that they can make their own decisions about reproductive health. The right to make choices about our own reproductive health and the right to bodily autonomy intrinsically align with our ethical standards as social workers. Social justice and reproductive health are tied together because individuals in low income categories and people of color are disproportionately penalized when reproductive health resources are not available. And again, this falls into women because we already know that women typically earn less than men. People of color, our black communities and our brown communities have less access to the reproductive health. And there's so much stigma, and there's so much prejudice, and there's so much uninformed opinions out there related to this that it becomes a hotbed for sure. But when we're working with the clients in the vulnerable populations we work with, we need to make sure, and we need to continue to work on their behalf and their interest, that they have adequate access to resources necessary for their reproductive health, because this also impacts their physical health and it impacts their mental health. What we do know is that I actually included this as one of your readings, this Sonnenfeld et al. 2013, and they used evidence from historical and current settings and broke down the findings relating to women's use of effective contraception in time and space of birth, or to abstain from childbearing. Social and economic outcomes related to educational attainment, workforce participation, economic stability, union formation and stability, mental health and happiness, and the well-being of children were all positively impacted when women had the right to choose when to have children. Societies are better when women maintain autonomy and a right to choose and adequate resources to decide when they want to have children. So we can take that evidence, and that's actually worldwide, not just in the United States, but this has been shown worldwide. So women's choice for reproductive health, for reasons we talked about earlier, and with women being the cornerstone of family and women being the primary caregivers and all of that, if we can actually empower women and provide them the resources, the education, in a non-stigmatized manner as to how they choose and when they choose to have children, again, it benefits all of us. It benefits the whole society. It's not just one pie anymore where we're all going after the largest piece. We can have multiple pies, and we can be creative and continue to cook enough pies that everybody gets a piece of whatever they want, if we just allow for this choice to happen. This is played out in research over and over again. Another vulnerable population that we're going to work with are going to be individuals of sexual minorities. And there's some, again, because of what we talked about in terms of social determinants, there's actually a lot of factors that play into the physical health of sexual minorities. Defined as sexual minority is a group whose sexual identity, orientation, or practices differ from the majority of surrounding society. And majority can be in numbers, and the majority can also be in power. Primarily used to refer to lesbian, gay, bisexual individuals, those who are transgender, those who are transitioning, non-binary, intersex individuals. Again, individuals who are not within what we deem as the majority of society from their sexual standpoint. When we look at health disparities among sexual minority youth, and there's many studies that have taken this approach because as youth, again, they're beginning to explore their sexual identity, they're beginning to explore their sexual preferences. This is a growing period, a growing time. But what we do know is that sexual minority students are at greater risk of negative health outcomes, and this includes HIV infection along with other sexually transmitted diseases. Now, this is not unique to youth because it's also the same for individuals who are of sexual minority who are of adult status. They're also at greater risk of HIV infection and sexually transmitted diseases. But what we do know about sexual minority youth when compared to their heterosexual peers is that they're more likely to be bullied in school, they're more likely to have been forced to have sex, they're more likely to seriously consider suicide, again, because of these other factors. Use illicit drugs, misuse prescription opioids, feel sad or hopeless. And again, all of these go into impacting not only the mental health, but the physical health and the actual way they take care of their bodies in a key period when the body is growing and changing, and from a physical aspect, establishing those healthy physical habits, not smoking, not using illicit drugs, not misusing prescription opioids, exercising, feeling confident in themselves, diet, all of that goes into place and begins to take formation right now when these youth are going through all of this. And so the things that are happening to youth who are of a sexual minority are going to have long-term impacts on their health. For those who are of sexual minorities in the adult realm, a lack of health insurance coverage is a problem, in addition to the non-recognition of same-sex partnerships, and these can be a barrier in preventing access to health insurance. A lack of culturally competent providers that are trained in the healthcare needs of those of sexual minorities is very difficult. Sexual minority women will tend to delay healthcare and are less likely to have a usual place of care, again, because of these systemic barriers that are in place for them. So they're at an increased risk for preventive diseases because they're not going in for their preventive care. Racial, ethnic, and sexual minority males are two of the most persistently unhealthy groups in the United States. Because we know boys and men of color are more likely to live in poverty, social determinant, have poor education and educational opportunities, social determinant, be underemployed and unemployed, social determinant, be incarcerated and to be exposed to toxic substances, both social determinants, to experience threats and realities of crime, social determinant, to live with cumulative worries about meeting basic needs, tied back to these other social determinants, and to have discrimination influence their capacity to achieve and maintain good physical and mental health. So not only do they have the barriers that racial and ethnic minority groups experience on a daily basis, now they have a sexual minority that adds to the barriers for that and accessing good physical care. Physical and mental health care, again, we just really can't separate it out. I've really pushed y'all to look at the physical care in this class because we don't always incorporate that, but it is tied to mental health, and we have to address both of them if we're going to help our vulnerable clients improve their outcomes. And individuals with mental illness, I just touch on this one very briefly because, again, it goes back to those social determinants and the chronic illnesses that we see across all the vulnerable populations are more pronounced with individuals who have mental illness. And again, it's going to go back to those social determinants, which are things as social workers that we can impact. So we know that people who are diagnosed with mental illness or experience poor mental health have higher rates of preventable physical illness. They consequently die earlier, with some groups dying earlier than the general population. Well, I apologize. That one is really messed up in my typing there. The main conditions, again, for individuals with mental illness, again, are cardiovascular disease, respiratory illnesses, diabetes, and cancer. All of those chronic health conditions that we've seen across this whole module. The interrelated factors include barriers to providing adequate health care, which includes access to health insurance, access to the physical providers, including the doctors and the clinics that are necessary to do that. If we're talking about individuals who have chronic mental illness, they could be homeless, they could be living in some form of group homes, so they have less access to those services, less access to transportation. And then the harm, the autogenic harm, based on the interactions with the mental health system. There's very much a us against them when individuals who have mental illness, and especially active mental illness, are in the system. And so there's these negative interactions with the system that then we're asking them to go and get physicals and go and get treated for medical conditions. So it just compounds everything. So when you're working with individuals who have mental illness, you have to be highly acute and highly aware of the social determinants that are there, as well as any of those preconceived thoughts, emotions, opinions, not wanting to go, and trying to impact that so that they could hopefully improve their health outcomes.